we'll go ahead and get started. So I'm going to try to do an overview of some bleeding things and some thrombosis things because there really wasn't a good split in the lecture series that they're doing for you guys. And so with that being said, there's a lot of points that I'm going to try to get through. Understand this is probably no one's favorite subject to talk about, bleeding and clotting, but we'll try to get through it. And I'll try to hit like some of the things that they typically like to have you focus on. So, see. Oh, there we go. Okay. All right. So the first thing I'm going to do is just there's three cases from a bleeding standpoint. I'm going to read through first, and then we're going to come back to them after we kind of talk about some of the overview stuff for bleeding. So the first one is a 4-year-old male that's scheduled for an upcoming tonsillectomy for appendicitis and snoring. Otherwise healthy, no other kind of history, and he comes in just for a pre-op evaluation. ENT is requesting that a baseline CBC and TT be done prior to surgery. He has no history of easy bleeding, no prior surgeries other than circumcision, but didn't have any excess bleeding with that procedure. So get the lab, CBC comes back and it's reported out as normal. PT was normal at 12 seconds, and then the PTT was mildly prolonged at 48 seconds. The second one is a 15-year-old female that's referred to for evaluation of veneregia that's poorly controlled by hormone replacement therapy. She's been extensively evaluated by her GYN and has no anatomical abnormalities, not sexually active, and urine pregnancy test was done 1 week prior that was negative. And then the last one is a 2-day-old male with persistent bleeding after a routine circumcision. Child is otherwise well, and physical exam is normal except for bleeding at the site of circumcision. All right, so we'll come back to those in just a second. But looking at all of the super kind of nitty-gritty things about hemostasis, they're not going to ask you super detailed things about hemostasis, but just kind of going through to set the stage a little bit. So when we talk about hemostasis, anything with bleeding and clotting, the important thing to remember is it's all about checks and balances. We have factors in our body that help us to clot when we need to clot, and then we have things in our body that help us to not overly clot when we don't need to. So it's all about the balance of those systems. Clot formation is typically initiated by vascular injury, in which you'll have a platelet plug that forms. It's then going to be reinforced by thrombin through an extrinsic pathway, and we'll kind of look at pictures to give an overview of that. There are physiologic anticoagulants such as antithrombin 3 and activated protein C that are going to oppose thrombosis, and so you always are trying to keep the thrombosis at the site of injury. You don't want it to start going haywire and going everywhere. And then clot formation is balanced by plasma-mediated fibrinolysis to break down those clots whenever they are no longer.
Excuse me, Dr. Ambrose.
Yeah.
For us virtually, I don't think we're able to really see your slides. We're still just on the first slide. I don't know if.
Okay.
It looks like it's not working for us here. Sorry, I just didn't want to miss anything.
Does anybody know if I have to hit a different button for them to see it?
Now I think now we see that you're on the steps of hemostasis. I think it's working.
Okay, I'm going to try to change. Do you see the next one?
Yeah, it's working now. It just wasn't working.
Okay, I wonder if I was still on the Zoom one, maybe. Okay,
awesome.
All right,
Thank you.
If it does it again.
Okay, so looking at the sets of hemostasis, what's going to happen is you're going to have a site of vessel injury. That's going to open up the endothelium, and that's going to expose von Willebrand factor. That von Willebrand factor is then going to call your platelets into play. You're going to have aggregation of those platelets, and you're going to form the loose platelet flow there in the middle. Once you do that, you're then going to need fibrin to come in and really reinforce that clot so that the bleeding doesn't restart again. So the two steps to that process are primary and secondary hemostasis. So the primary hemostasis, all that means is the steps that you need to get to that very loose platelet plug, okay? Secondary hemostasis is the coagulation cascade that makes everybody cross-eyed, okay? Nobody's gonna ask you about having to memorize the coagulation cascade. But just know that once you get that platelet plug there, on the surface of those activated platelets is going to be the setup for all of these factors to come in and essentially get you to the cross-linked fibrin at the bottom to get to officially stop. So let's talk about kind of how to approach it. So you have a kid that shows up and they're having some sort of bleeding symptom. So what do you want to know? What do you want to think about? As with everything in medicine, getting a really good history is going to be important, all the way from anything that's happening with the child to family history. So you want to know when they come in with bleeding, what was the age of onset? Is this something that's been going on their entire lives and maybe it's just now worsening? Or is this something that is an acute onset and never had any prior? So that's going to kind of help guide you a little bit. What is the sex of the child? Obviously, as you guys know, there are some of these that are going to be X-linked. So are they male, female? Kind of helps point you in one direction versus the other. Frequency, how frequent is the bleeding? So nosebleeds in Gen Peds is going to be a super frequent complaint that you're probably going to see. Not uncommon to have kids that have nosebleeds. Doesn't mean that they necessarily have a bleeding disorder. So really honing down and thinking about frequency. When a child, when a parent has a child who is having any sort of bleeding, you know, if it happens more than once, it's probably going to be in the parent's mind it's happening all the time, lasting for hours. When in actuality, if you really try to get them down to it, oh, well, maybe it really is just a few minutes. Maybe it's really not happening every single week. Maybe it's just, you know, once a month or something like that. Really just kind of getting them to focus on how often it's really occurring. Then what is the location? So if they come in and they're having nosebleeds, do they have any other associated symptoms? Do they have any easy bruising, any mouth bleeds? If they're female of menstruating age, they have heavy periods. Have they ever had any surgery? So that's a big one to ask as well, because not that it can't happen. You can certainly have some milder bleeding disorders and have had a minor surgery and not had any complications. But it becomes less likely that you have any sort of major bleeding disorder if you had surgery and you can find it. So knowing their surgical history. A lot of kids will not have necessarily had surgeries. Ask about dental stuff. Have you ever had teeth pulled? Because a lot of these bleeding disorders actually will present with tons of bleeding if they have teeth. Mucosal bleeding tends to be something that we see very frequently. So make sure to remember to ask about any dental stuff too. And then we kind of talked about duration of bleeding. How long is it really lasting? Are there any associated symptoms with it? You know, kind of thinking outside of, is this just a bleeding disorder or is there something else going on? So, you know, have they been sick recently? Have they had issues with fevers? Do we need to worry about any of their other blood counts, things like that? And then that kind of goes along with review systems. So what are the features of abnormal bleeding? So with nosebleeds, you typically think that there is something definitely not right about a typical nosebleed if it's unrelieved by at least 15 minutes of pressure. Now, really got to ask them, did you really hold pressure, not let up for 15 minutes? That's really hard to do. I think it would be hard for any of us to do. But truth be known, even in just a regular old run-of-the-mill nosebleed, if you don't hold pressure for that long and it hasn't had time for that initial platelet plug to form, or if it gets knocked and you let go of that pressure, it's going to leak. That's just the way that it works. So really getting them to make sure that they're holding good steady pressure for at least 15 minutes. And then if they ever had to go to the ER because they could not get it to stop. Now, definitely had ones that ended up going to the ER, but it was more so for, like, oh, it was bleeding really bad. I couldn't get it to stop. But by the time I got to the ER, it was done. So, you know, did they really have to go to the ER for it, or were they just nervous that they couldn't stop? Menorrhagia, obviously something that we very frequently see as well. So really kind of getting them to quantify how much bleeding that they're having, how frequent are their pad changes. They're having to do it more than every 2 hours. That's not normal. Are their menses lasting longer than 7 days? That's typically a sign that something's going on, or not exactly exactly right? And are they having more than one menstrual period a month? Now, as you guys have seen, maybe not necessarily due to a bleeding disorder, any sort of hormonal imbalance and things like that will definitely cause menorrhagia as well. But certainly just questions to ask to see if it's truly menorrhagia, how heavy is it? Post-surgical or dental work, do they have any bleeding with that? Any uncontrolled bleeding in the field? Prolonged bleeding after they've had dental work? Do they ever require blood transfusion? One of the stories that I always tell is there's a family of type 2 von Willebrand's. Dad has it, and his entire life he was labeled as a free bleeder. His grandfather was labeled as a free bleeder. That's just what they always told him. And so nobody had ever given him the actual diagnosis. And so this dad went and had a routine dental extraction done and almost died because he bled and bled and bled and bled. It wasn't until after that that they figured out he had type 1 Willebrand's. So he's now terrified to go to the dentist, even though we know what he has. But that just goes to show that some of these patients legit can really bleed with those procedures. So that's obviously not normal. And should prompt anybody to do a workup for those people. And then bruising. So another super frequent complaint. Bruising here and there is certainly normal. So when is bruising not normal? Obviously, bruises that are in places that aren't on the extremities, not your typical, oh, this is a place you would expect to find knock and end up with a bruise. If they're larger than quarter size, that starts to kind of raise concern because unless there's some mechanism that would fit, usually most random typical bruises aren't going to be bigger than that. Are they associated with hematoma? So underneath, do they tell you, yeah, like it got like really bruised all over and there were these really hard areas? That's usually a sign that it's probably developed with hematoma. Now, that can happen to anyone without a bleeding disorder, but in general, if it doesn't fit the mechanism of injury of what they had, it seems to be out of proportion, then that makes you kind of start to think what else could potentially be going on. And that was the last one. That was proportion to injury. So other pertinent history, obviously with most under congenital bleeding disorders, you're going to have some sort of family history. Absolutely, you can have cases where that's not true. I have quite a few hemophilia patients that have been diagnosed within the last few years that actually there is no family history that actually started with a child. So it's not that it can't happen, but it can help guide you as to whether or not, oh, could this be something going on? When I see females a lot of times with menorrhagia, asking them about bleeding history, it's also important to ask mom, did you also have heavy periods? Did your sister have heavy? All of these people, and I'm like, oh, well, now that you mention it, you just always thought that it was normal, and nobody ever did anything about it. So that can help you. Did anybody require transfusions for minor surgeries, postpartum hemorrhage, early hysterectomy? That's another big one. And von Willebrand's tends to be the one that gets missed most often. That was another story that I had, was a little kid that came in to be worked up for von Willebrand's because his mom had just been diagnosed after they told her the only solution to stop her bleeding was hysterectomy because they didn't know she had von Willebrand's. So she went through all of that and really didn't. So asking about early hysterectomies because of bleeding is important. Chronic iron deficiency anemia can sometimes lead you, if they don't really think their periods are heavy, if they've had a strong family history of, oh, all the females have iron deficiency anemia, well, it could just be because of lack of poor diet, but it could also be because they're bleeding out of proportion to what you would expect to be normal. Medications tends to be less common of an issue in kids, but ask about aspirin, ibuprofen, and herbal medicines that they're on to see if there are any sort of interactions. One of the fairly common referrals that I'll get is for bruising, and a few times it's been a kid that's come in and they've been on Zoloft, and Zoloft causes an intermittent platelet dysfunction that can lead to easy bruising. Most of the time, it's not to the point where patients have to come off of it, but it usually is enough to explain their easy just asking about other medicines and stuff that patients are on. And then surgical history, like we kind of already talked about, just wanted to know if they had any complications with that. All right, so physical exam. Most of the times when you're evaluating these patients, not necessarily going to see anything on exam, particularly if this is something they're coming to you in the office for. But just other things to kind of keep in mind. What is the general appearance of the child? You know, if you're worried about a congenital bleeding disorder, you would not expect someone to show up with ill hearing. That usually doesn't fit. So is there something else that's obviously going on? If they come in and they said they've had really good bruising, oh, but they've also been really fatigued, oh, they've also had fevers, okay, well, that is leading us down a little bit of a different path than bleeding disorders. Look for signs of bleeding, so certainly petechiae, bruising, any joint swelling with some of the disorders can be apparent as well. Look for signs of infiltration, which will point you kind of away from bleeding disorder, but could this be a malignant process? So hepatosplenomegaly, significant lymphadenopathy, things like that. It is rare that the bleeding stuff would be the first presentation of something like leukemia, but it certainly can happen. So just keeping in mind, is there anything else on exam that you feel is like, oh, that's not normal, can help kind of guide you. And then there are a lot of different syndromes for one reason or another that can lead to increased bruising and increased bleeding, those sorts of things. So look for any syndromic signs, dysmorphic features, papillary spots, cholangiotatic vessels for sure. If you see hemangiomas, think if you see several of them, think do I need to look inside? Are there ones larger that could be causing a consumptive process that then by nature ends up leading to things like low platelets, easy bruising, stuff like that. It's going to be more rare, but just something to kind of think about. So where do you start with lab evaluation? Honestly, it really depends on what the symptoms are that they're presenting to you with and kind of what you're thinking on your differential of what may be going on. But some of the good screening things certainly are the first 3 or 4 up there. So CBC for sure, look at your platelets, see what are those normal in number. The peripheral smear can help tell you any normal in size. Getting a PT-PPT, that's a good marker of the integrity of that coagulation system. So that secondary hemostasis with all the fat clotting factors. The PT-PPT is a good measure of is that intact or is something broken down somewhere. So getting that can be a good screen. And then fibrinogen, I think of fibrinogen a little bit more whenever patients have delayed bleeding. So those patients that come in and they say, oh, they had a tonsillectomy, and they were totally fine during the procedure, and a week later they started bleeding. You usually see it a little bit more with fibrinogen than it's delayed. Can certainly have other types of bleeding with it, but that's one of the false. So usually those are some of the first 4. On Willebrand panel for sure, if it's a female with menorrhagia that comes in the office, you're not going to be wrong sending them on Willebrand panel. Most of the time, even if they come back abnormal, they're going to get repeated anyway because those levels can certainly be transient. So you want to make sure that it truly is, that it really is abnormal. But you certainly wouldn't be wrong getting this in the office. The thrombin time is measures the function of your fibrinogen. So when you measure fibrinogen, it gives you a number. The thrombin time tells you the activity level is working where it's supposed to. And then the PFA 100 is a replacement for the bleeding time. The bleeding time was a manual test that was wrought with dysfunction and can often be read wrong. And the PFA is an automated test that is more commonly than screening. Most of those are not going to be ones that you would get in the office, but are still things to consider and think about. So this is just kind of, they have a lot of these different flow charts. I'm not going to go through everything on here, but this is kind of good just to kind of keep in your back pocket to think, because if you're doing general pediatrics, all of the nitty gritty of bleeding stuff is not going to be on the tip of your tongue every single day. So having something like this to kind of say, okay, I need to just think, what should I send on this patient? Which direction should I go? Ones like this will be helpful just to kind of say, oh, okay, let's send for, X, Y, and Z based on what the presentation is. So these are really good to kind of think about having. All right, so let's go back to the cases for a second. So remember the first case was the 4-year-old that's going to have the tonsillectomy, totally normal otherwise, no history of bleeding. You asked about family history. There's no family history of bleeding. Mom and dad have never had any concerns. But on screening labs, you find everything's normal except for a mildly prolonged PTT of 48 seconds. Anybody know what you do when you have an abnormal PT or PTT? What's the next step?
Repeat.
Well, absolutely, you could repeat it, but if it's still abnormal, before you do that. So the other thing to remember is mixing studies. So a mixing study is where you take normal controlled plasma and you mix it with the patient, because remember the normal is going to have all of your clotting factors in it. So if you mix it with the patient and it corrects, then that tells you, oh, I just added in some factor and it got better. If you mix it in and it does not correct, then that's a sign that the patient may have an inhibitor. Okay. So you do that on this patient. I forgot about this stuff, but there's some explanation of that. And so we do this on our patient, and the mixing study comes back and essentially is really unchanged. 48 before. So that tells us, okay, I just took normal plasma and I mixed it with our patient. He had all the clotting factors in, it didn't get better. So there's some form of inhibitor there. This is probably one of the most common pre-op things that we see, is an acquired inhibitor of coagulation. Most of the time, this is going to be due to some viral something kid that has led to some inhibitor formation. Most of the time, these kids are completely asymptomatic. They have no issues with bleeding whatsoever. And then, of course, the surgeons always want to know, okay, what does that mean we can proceed with surgery? More than likely, the kid will be fine. More than likely, you could probably proceed with the surgery and won't have an issue. The problem is that you can't guarantee that. There is a slight inhibitor there. Could they have some increased bleeding? Potentially. There's no way to say for sure one way or the other. So oftentimes what we'll tell the surgeon is, hey, if this is a surgery that can be delayed, I would move it out 6 to 12 weeks, because most of the time those are going to self-resolve as the child's recovered from whatever is caused it. If it's something that they're like, no, they really need it sooner than that, then our recommendation is usually, okay, proceed, and then just be ready with supportive care measures if the kid would have increased recognized. Most of the time, the surgeons don't like that answer, so they'll just wait. But occasionally there have been times where they needed to proceed, and I don't think I've ever actually seen somebody that's had this set up that's gone on surgery. Most of the time they don't have problems. Usually they'll want you to retest, and there's a couple of them that we have, and they generally have resolved. I don't think I've really seen that. All right, so then the other classic case that I'm sure you guys have already seen a lot is the teenager that comes in with menorrhagia, poorly controlled bowel hormone replacement therapy, and they just want to, the GYN just wants them to be worked up because it doesn't seem like this is going down the path they would have expected. So looking at her past medical history, it's negative, except for she did have recurrent nosebleeds as a preschooler. She was treated with nasal cautery for that and had good results. So the labs that you get on her initially are CBC, that's normal platelet count, normal hemoglobin. Get a PT that's normal, a PTT that is just outside the upper limit of normal at 39 seconds, and then the PFA 100, that bleeding time, that is a little prolonged. What is it? Super. So Von Willebrand factor is synthesized in megakaryocytes and endothelial cells. So remember when we talked about initially with the primary hemostasis, you have some vascular injury, that endothelium is exposed. Von Willebrand is one of the first things that it sees. And so it's instrumental in calling in your platelets to start that plug. So it has two primary functions. It does serve as a carrier protein for factor VIII, and it aids in platelet adhesion and aggregation during their initial stages of coagulation. So oftentimes patients with von Willebrands, you will notice that their von Willebrand factor is low. Their factor VIII oftentimes is low too, because it's a carrier protein for it. It's by far one of the most common inherited bleeding disorders. It affects up to 1% of the general population, maybe more than that. It's important to remember that men and women are affected equally, but women are much more likely to present because they're the ones that are going to have the more severe symptoms because of pregnancy. And so that's why if I get referred a female for menorrhagia, almost 100% of the time, I'm going to screen for von Willebrand, because there have definitely been ones that we have found that had no other bleeding symptoms whatsoever. Outside of von Willebrands, there's really not another bleeding disorder that you would expect to see that. But with von Willebrands, you may just have heavy bleeding. And so usually I'll screen all of those girls. So there are three main types, type 1, 2, and 3. Type 1 is by far the most common. It's autosomal dominant, and it's a quantitative defect, meaning you make von Willebrand factor, you just don't make enough of it. Most of those patients have mild to moderate bleeding symptoms. So these are the ones in the boys. They typically will have nosebleeds, easy bruising as a child, and then as they get older, their symptoms disappear. And then in females, you may have some nosebleeds when they're younger, and then they start their period, and that's when they really start issues with heavy bleeding. Usually your lives with that, you'll have a decrease of von Willebrand factor antigen, so the amount of von Willebrand factor, and then sometimes you can have a decreased risk of seton, so that's the measure of the activity of your von Willebrand. Some of them may have a decreased activity. And then, as we talked about, a low to normal factor VIII level. Type 2 is the second most common, usually autosomal dominant, sometimes can be recessive. These patients usually will have normal amounts of von Willebrand factor, but there's something wrong with it, so it doesn't function the way that it's supposed to. There are 5 different subtypes of type 2. And it just depends on which one of those is of the von Willebrand and how we get which subtype that they are. These patients may have also mild to moderate bleeding. I will say that you do typically have more bleeding with type 2 than type 1, especially the females. So the females with menorrhagia that end up being type 2, they typically have a harder time. So usually your type 1 patient, if they have heavy periods, send them to GYN, because being on hormonal control is probably going to be the best thing to help them. Sometimes that's not always the case with type 2. And the reason that it works for type 1 is because, remember, their von Willebrand that they make is normal. It usually works fine. They just don't have enough of it. But when you put them on estrogen-containing medicine, it helps to raise that von Willebrand level, and so it tends to work better. With the type 2, it's hit or miss. I've had some girls that'll do great, and their periods will be more controlled on the hormonal replacement, and then I've had other ones that have bled, despite being on hormonal control. Thankfully, it's not as common, but I do have one shortly after I started, poor girl. I mean, she was only in her early 20s, and her life was miserable from all of the bleeding, because she was bleeding constantly. And so she finally was like, I'm never going to be able to have a baby, because nothing that we do is working. I don't even want it at this point. I just want hysterectomy. And so we actually had to fight with insurance companies and fight to find a GYN that would actually do it. But she finally, about a year or two ago, did get her hysterectomy. Thankfully, that is not common. Most of the times we're able to get these girls under better control so that that's not the case. But she just had a particularly bad subtype. And then type 3, thankfully, is the least common, is autosomal recessive in the most severe form. With that one, you just don't make von Willebrand's at all. So remember, we said von Willebrand's is a carrier protein for factor 8. So if you don't make von Willebrand factor, your factor 8 is going to be pretty low. So a lot of the type 3 patients will actually function like hemophilia. And so they're ones that can have joint bleeds, they can have repetitive bleeds. A lot of times those patients also have to go on prophylaxis several times a week to be able to help control their bleeding. So symptoms we've kind of already talked about: easy bruising, nosebleeds, heavy periods, and have postpartum hemorrhage, particularly if they're not treated, post-surgical bleeding, and then dental procedures. So how do we treat it? Kind of depends a little bit on what type it is. So with type 1, we may be able to use DDAVP because it stimulates the release of von Willebrand factor in the plasma. The thing is that not every patient will respond to it. So it's important before we prescribe this to patients that we bring them into clinic and we actually test their levels before, give them a dose, and then we usually do 1, 2, and 4 hour post levels to make sure that they're having an appropriate response. Amicar is a supportive care medicine. It's just an antifibrinolytic. So basically, once you get that fibrin clot there, it keeps it there and keeps it from breaking down. So we use that a lot for mucosal type bleeding. And then if DDAVP doesn't work, or if you have type 2 or 3, then the only thing you can do for these patients is to give them von Willebrand factor back. Unfortunately, it's all IV medications. So if these patients are very severe, then if they have to go on prophylaxis, most of the time they're going to have to deal with it at home. If they're super, super young, and you have to talk about putting a fortune to be able to treat. Okay.
Yeah. So I'm an adolescent right now, and got one in the time clinic. I actually helped her injury or work with von Willebrand. She was like right in the middle of it, like her first von Willebrand, so like, and then you send her over sooner than next month for repeat labs. Our question yesterday was, we want to start hormonal therapy. Do we make these go after the repeat labs are done? Maybe start.
So in general, because it used to be that we were afraid that putting patients on estrogen, especially if you worry about type 1, that if you put them on estrogen, you may increase their levels of von Willebrand. So we're missing a mild type. But what it's honestly been found is unless you're putting them on high dose estrogen, it's really bad. So most of the time, just starting them on a typical birth control is not. So I would rather go ahead and get your periods and stuff under control. Those ones that are right in the middle are really hard because you have to think, you want to label somebody with von Willebrand for the rest of their life because that's going to have implications with insurance. It's going to have implications for things that you have to do down the road. So if a patient's only symptom that they have is just menorrhagia and they fall within that 30 to 50% range, because less than 30% diagnosis right after that. But if you're between 30 and 50%, it's this questionable range. I've certainly seen patients that have all the symptoms of von Willebrand's in that range, and I have no problem calling it. It's these ones that it's just menorrhagia, never had nosebleeds, never had any other problems whatsoever, and it's like, do you do it or do you say that they have or do you not? And so those are the ones that are always really, really tricky. Most of the times, if I'm doing it, I'll usually repeat their workup and then send them. So I guess maybe that was when I got there before they got their repeat Gotcha. So it's definitely not wrong when you start it. It's not going to affect it to the diagnosis. All right, and then the final bleeding case is a 2-day-old male, persistent bleeding after routine circumcision. The child's otherwise well, except for the bleeding at the site of circumcision. I'm just gonna kind of roll through this and just go off the line. So you do screening labs on this kid, and the PT is normal, PTT significantly prolonged. So see how much more that is prolonged compared to that first one. I've never seen a PTT that's this high that didn't turn out to be effective. So most of the time, whenever I get labs like this, I don't even mess with a mixing study because this has got to be a factor deficiency that's causing this. So in this case, if you have a normal PT and an abnormal PTT, what two factors do you look at? This is something to, and you're not probably going to remember this on a day-to-day basis, but before you take your board, that week before, this is the stuff that you're training your head. So if your PT is normal, but your PTT is prolonged, most likely a board question is going to be it's either factor. That's the okay. If your PTT is normal, but your PT is abnormal, think factor 7. Okay, that's probably going to be the most common thing that you're going to ask. Those are the types of things that you're just going to like put on a flashcard, look at it a couple of days before the test, and then you're going to forget it. Because in the real world, you can. Okay, it's not as pressing, but if they're going to ask something about that, those are usually the ones that they'll ask. All right, so on this kid, pretty much knew that it had to be a factor deficiency. Just for sake of this, we said we did a mixing study and it corrected because we added the factor back. So we checked this kid's factor 8 level and it was less than 1%. So it was diagnosed with hemophilia A. So hemophilia, X-linked recessive disorder. And with hemophilia A, we know it's factor 8. Hemophilia B, we know it's factor 9. That's a factor. You grade the severity based on what their baseline factor level is. So if you're less than 1%, obviously that's severe. Those are going to be your patients that are going to bleed for no reason. They'll just wake up one day and they're like, my knee is huge and I have no idea. They can bleed really quickly and they can bleed really badly. Moderate 1 to 5% is really all across the board. I have some moderate patients that never bleed. I mean, it's like they don't even have hemophilia. And I have others that bleed just like this. It's really crazy. It really depends a lot on what their type is. It's all across the board. Mild, it obviously does much better. They only rarely have joint bleeds. And they usually only bleed with major trauma or surgery, and their levels are between 5 and 30%. So with von Willebrand's, your problem is that primary hemostasis. Your problem is trying to get your platelet plugged. With hemophilia, you can make your platelet plug, but it's pretty weak. You can't reinforce it with your fibro because you're missing factor 8 or factor 9. So that's the problem with hemophilia. So neonates bleeding with circumcision is going to be your most common presentation. In the infant and toddler ranges, honestly, what I've seen more often than not, if they haven't been diagnosed at that age, is because of really bad bruising. Usually that's one of the first things that I'll see, but they can certainly have oral bleeding. We've had a couple of our patients that have been readmitted multiple times because of frenulum bleeds. They'll fall, they'll hit their mouth, and the frenulum will tear. And it is the worst place to get a bleed because you have enzymes in your saliva that break down these clots, and so they just keep bleeding. It's so frustrating to treat. It's obviously frustrating for families. Obviously, infants and toddlers are more mobile, so that's when you start to worry more about their joint bleeds, like that. Ask about family history because obviously that's going to be a big thing. Don't forget females. This is like a big discussion right now in the bleeding disorder world because for years people would just dismiss females and they're like, oh, you're female. Well, not really true. So they're definitely less likely to be severe, but a female carrier most likely is going to have a lower factor 8. Okay, and there are some that are so low that they're technically in mild hemophilia. And if that's the case, they will be diagnosed with mild hemophilia. So if you have a female that comes in and they are having bleeding symptoms and they give you that family history, my recommendation is check a factor VIII level, and then we'll figure it out from there.
The Russians and stuff. Are there like any ethnicities that have hemophilia more commonly, or is it
Not really.
Okay.
It's pretty much across the board. Now, I don't think we have as many, and I honestly have to look this up, but just speaking from our patients, there are fewer Hispanic, but we certainly, I would say it's probably a mix between the others. It's pretty much affected. So. And then obviously 30% of cases may have a negative family history. Those are the ones that are always the hard blows for families. The ones that know that it's in the family are not really surprised. But these ones are like, no, we don't have anybody that when their child gets it, it definitely rocks the world because they're not prepared for all you have to do and what you have to monitor for. So bleeding complications in these patients, obviously the one that we worry about long-term are going to be your joint damage. So we know that you can start having joint damage after your first joint damage, okay? So our goal is to try and have kids never have it. Now, probably not going to happen, but we try. So usually we don't start prophylaxis on these kids unless they have a lot of bleeding issues once they start walking. We usually try to start prophylaxis by 2 years of age. And this is why we want to help prevent this complication. I have guys right now who never did what they were supposed to do with their prophylaxis and treatment, whose joints in their 20s are complete trash, and they already need joint replacement. And finding an orthopedic surgeon to do that in your 20s is not likely to happen. So these guys live with chronic pain day in and day out, and they look at me and say, I wish I'd done what I was supposed to do. So this is a really big deal and can kind of be life-altering issues for these patients. Muscle bleeds are a little less common, but there are some phenotypes that are more prone to muscle bleeds. And you can see the ones that have had a lot of them. You can look at their extremities and see that one is clearly different from the other. They'll get a lot of atrophy from repetitive those muscle bleeds. And then the other thing to be aware of, if you ever get a phone call that a hemophilia patient has a muscle bleed, I would always send them to the ER. Most other bleeds, I can talk them through it in terms of treating at home, but muscle bleeds, you have to worry about compartment syndrome. So I always tell them it needs somebody to look at it to make sure that this is not something that has some sort of surgical intervention. Subdural hemorrhages, thankfully, are less common, but certainly can happen. Inhibitors, if it doesn't suck bad enough that you have hemophilia, it is even worse that you can develop inhibitors to the factor that you're giving. So then that really just throws everything off because that limits the treatment options that we have. We're not going to go into it today because I don't have time, but there is a new medication that a lot of our patients are on called Hemophilia that actually bypasses that factor pathway. And so it has been a game changer and lifesaver for patients who have hemophilia inhibitors. So we're getting better at treating them, but we still have a ways to go. And then unfortunately, I mean, I see patients through the lifespan. So unfortunately, I have several adult patients who have HIV and or hepatitis because they received treatment prior to 1994 when blood products and things like that were not screened the way that they are now. And they are now with us. I actually had one right before I came up today who has thankfully been treated for the hepatitis B, but still has HIV and is on ongoing treatment for that. So how do you treat this? This is a big thing to kind of remember because this is still what boards is going to ask you if they're going to ask you about hemophilia treatment. The things that you want to know is that with hemophilia A, if you have to do replacement, it's a 1 to 2 correction. So for every 1 unit per kilogram of factor VIII replacement that you get, it raises your factor VIII level by 2%. Okay. The half-life is about 12 hours, but with hemophilia B, it's a 1 to 1. So for every 1 unit per kilo, you're going to raise your factor IX theoretically by 1%. Those are the things that they're going to want to know. So, you know, they say if you get a hemophilia patient that comes in and they have a bleed and you want to correct them to 100%, how much are you going to give them? Well, you would give 50 units per kilo for a hemophilia A patient, but you have to give 100 per kilo for a factor IX. And then just things that we kind of think about in terms of treating. So minor bleeding episodes are going to be your early joint bleeds, soft tissue, muscle bleeds, bleeds, gum bleeds. Those are the ones we try to correct to about 50%. So factor 8, 25 per kilo, factor 9, 50. The major ones you're always going to correct to 100%. Okay. But the big thing is if you are ever unsure, don't sit there and try to figure out which category it goes. If you are ever not sure, you just give them 100%. Okay. I'm not worried about you giving too much one time. I am worried about you not having complications. So particularly remember this in the ER, especially if you don't know mechanism of injury and all those things, correcting to 100%. All right, so we're going to try to go through some stuff for thrombosis. This is something that we are obviously seeing lots and lots more of. I think that we're doing a better job of screening patients, and I think that we are seeing patients who are much sicker. And so because of that, I think we're seeing a lot more of this thrombosis. So we all know what a blood clot is. Virchow's triad, I've never in my life would have thought I could quote Virchow's triad when we learned it first in school as much as I do now. But I explain this over and over and over again because it doesn't matter what your genetics show. It doesn't matter anything about your underlying kind of blood work. At the end of the day, if you give anybody the right setup, you're going to form a blood clot. And it's because of this. If you have blood that's cystic, if you have injury, overwhelming inflammation, things like that, you're going to form a clot. It doesn't matter what your family history is. Yes, that can make things worse. But families come in and they want reassurance, right, that their kid isn't going to have a clot. We can do a thrombophilic workup, but if that comes back and it's completely negative, I still can't tell you what a clot. So you've got to remember that it's important, no matter who you are, it's important to avoid things like dehydration, obesity, smoking. If you do have a strong family history, I would say if you can, avoid estrogen-containing medicine. You may be fine, but I can't promise you. Only know that increases your risk. All of these things are what I go over with families because I don't want them to walk away with a false reassurance if we do labs. Okay. There is a bimodal distribution. So newborns, I don't know if you guys have noticed over in the you do see clots a lot over there, and it has to do with babies just by nature are procoagulant. So they're born with lower levels of protein C, protein S, anti-inflammatory. They're not going to reach adult levels until they get a little bit older. It's even worse in premature sickness. So they are already set up for clots, and that's why. As they get a little bit older, that will correct. But they are, when they are sick, in ICU type settings, they're much more at risk of forming clots. Adolescents, because your vasculature system and everything starts to kind of lean more towards the adult side, they tend to be more at risk of clots. We're seeing it more with a higher degree of obesity. We're seeing kids who are sicker. All of that is mimicking very much the adult cardiovascular system, and on the adolescent side, we'll start to see a lot more clots. That's why with the VTE screening that we do, we start slow. Because anytime after that is when you really start to kind of see an uptick of blood clots in patients. So we're not going to go over all this again, but this just kind of goes back as a reminder. We looked at this at the beginning about bleeding, but just exactly what I said in the beginning of things. Once you get to this fibrin clot, you want to make sure that it stays where it needs to stay. You don't want that going anywhere else. You don't want your body to start throwing clots in other places. And that's exactly what can happen in the setting of inflammation. That's why patients who are hospitalized, who are really sick, who are in ICU, they're more at risk because they have, their body is basically going haywire with all of the inflammation. And that really puts a damper on the system that normally keeps. They're not going to ask you about any of this type of stuff on boards, but the thing that I like about this picture, because I can't even quote it to you, but this just goes to show there are so many different pieces to keep you in a check and balance. And any deficiency of any of these things can lead you to either bleed or compulsive clot. Okay. This basically just talks about fibrinolysis. So once we get that fibrin clot there, we obviously don't want it to stay there forever. Once that vessel repairs the way that it needs to, we want to break that down. And this just kind of goes over that pathway. I would not really expect them to ask you about this. We won't spend a lot of time on it. All right, so thrombophilia. So it's a propensity to develop thrombosis. And it can be applied to anybody who develops a spontaneous clot, has a VTE with severity out of proportion to the stimulus, has a recurrent clot, or has a clot at the young age. There's a wide range of definitions for this. It may also be used to describe patients who have inherited factors. So what leads to thrombophilia? We're not going to go over all of this, but there's a ton of different things, you know, from age to what else is going on. Do you have a central line? What drugs have you gotten? What underlying conditions do you have? There are lots and lots and lots of different things that can put you at an increased risk of clotting, which is, again, this right here is another reason why there's such a big push in hospitals across the nation to screen patients, because when they come in, all of this stuff is magnified, and so they are at increased risk of blood clots. So we're trying to identify those patients earlier and prevent some of the harms. That's just what the screen looked like before that. And then, all right, so inherited thrombophilia is always the number one question we're going to get asked whenever a patient presents with a clot, right? So the big question is, do we need to test the patient? And then the question that always gets asked of me is, once those results come back and something's abnormal, what do we do with it? The thing that's really frustrating about clotting is there's so many gray areas to clotting. Bleeding is a little bit cleaner, okay? There's something missing. We got to replace it to get you to stop bleeding. We can kind of do that. Clotting, you can treat it, but when the question becomes, is it going to come back? What, you know, does family history play a role? Yes, it does, but to what degree? And those are questions that we really don't have great answers to yet. So with inherited thrombophilia screening, it's difficult to decide who to test and who not to test. In general, what I typically do is, if it is a patient that comes in and they have risk factors that make sense. Okay, so let's say that you have a 17-year-old obese female, just started oral contraceptives, had knee. Well, she just had a whole lot of setup for doing that. And you get a family history and they say, yeah, there's no family history that we know of clots. You wouldn't be wrong not to test that patient, because she had tons of setups to lead her to that place. And so I've had a few of those patients that I've followed up outpatient. We've talked through the risk factors and families have been fun. There are other ones that give that same setup and they tell you, oh, XYZ, all of these people in the family had blood clots. Okay, well, let's test to kind of see where we are. The big thing is really talking to families about what we're going to do once that test comes back. So this is kind of a general tier 1, tier 2 type of test. For where we start with inherited thrombophilia. You may see varying degrees of this, especially in the hospital. If you guys haven't already heard, I'll say it now. It can be very difficult to interpret these tests in the setting of an acute clot. If you've got a patient who's sick, you know that you've got known blood clots everywhere, and it's not a simple test. The genetic stuff, like your factor V Lyme gene mutation, yeah, sure, you can send that. But if you send your antichromin 3, your protein C, your protein S, those are very important proteins in helping you to break down clots. And so if you try to test in the setting of all this stuff, so it's not wrong if you do it, but when you call and say, what do you want us to do? Probably nothing. You're just gonna have to send them to me because there's not really a whole lot you can do. So if you have a patient with a known clot in the hospital and you are treating that clot, I'm totally fine if you don't send it. Because I can just do this all as an outpatient. Now, of course, the question may come if you've got a complicated family, you don't know if they're going to show up and that's totally fine. But in general, I'm not going to be mad if this is not good because it's not going to change anything about your current family. All right. So this is kind of stuff that you guys all know, like when to think about, when do I suspect a clot? If they have a central line, it's not functioning, it's a clot. If they have an extremity that's swollen, hot, red, painful, okay, we need to look to see if there's a clot. PE, cough, shortness of breath, tachycardia, kind of got all of those. Remember asking history on these patients. Family history is super important, as well as personal history, what medicines they're on, what have they been doing recently before all of this happened, are all good questions to ask. You're worried about extremities, definitely do blood work. That's going to be the best thing to diagnose and for us to be able to follow. If you're worried about a PE, order a spiral chest CT because that's going to give you your greatest yield, and it's going to be the easiest thing for us to follow as an outpatient. And it makes it so much easier, if possible, if you can get the same imaging that I'm going to have to follow it with. That way you're comparing apples to apples. Any sort of brain stuff, that's when you're going to get MRIs to look for clots there. But that is generally one of the only times that you would do MRI. All right, so one of the things that's really important to tell families whenever you put these patients on anticoagulation for a clot is that anticoagulation is not going to break down that clot. Because families have sometimes unrealistic expectations that we're going to put you on this medicine and the clot's just going to go away. That's not what it does. The only thing that this medicine does and why it's so important is because you want that clot to stay where it's at. You don't want it to move, you don't want it to grow. That's what the job of anticoagulation is. Your body, that whole fibrinolytic process that we talked about, your body is what's going to get rid of that clot. But the caveat to that is these patients that we are seeing that are sicker and bigger clots, most of the time the body's not going to be able to get rid of it all. Okay, and so preparing families for that is very important because they will sometimes be very angry and disheartened when I do follow-up scans and they're like, it's still there. So that's probably never going to go away. And so then we have to kind of talk through all that. Your body is very, very smart. It can create collaterals around clots if it has to. It can chew through clots and start flowing blood through that way. You don't really know until you follow the clot exactly what it's going to be. But as long as you're getting blood flow, that's the important thing. But families oftentimes will get very stuck on that chronic clot. Once a clot becomes chronic, it's not likely to go there. It actually will become a part of your vasculature and stay there. So the risk of embolization, because that's what families are always afraid of, the risk of embolization is low once you have a clot. Yes.
I know that you repeat the testing after you finish your course with the medication, but how often and for how long do you continue to follow this after that? If it's still the same?
Oh, you're talking about if it's chronic? Mm-hmm. So if it's chronic and I'm stopping, I don't follow it because you're just going to see the same thing. The only time that I would repeat it is if the patient's starting to have their symptoms. And that's one of the things that I do want to get to on here is complications from that. And so sometimes one of having to repeat just to make sure that there isn't anything new, but you're not going to have any benefit once that clot becomes chronic. You're not really going to have any benefit following it. It's going to be the same. So standard heparin, so that's your heparin drips that you put patients on. Most of the time it's going to be in the unit, and most of the time you're only going to do that if you think the patient could potentially need a procedure in the next few days. A lot of times if it's head stuff, and neurosurgery's not sure if they're going to have to do something, they like for them to be on heparin drips so that they can stop. This is the last thing I want to talk about. So with these really, really big clots, okay, if you get a lot of occlusion there, you're going to lose some of the sensibility of those vessels. Okay, that is going to, if your body is not able to completely clear that clot, oftentimes what ends up happening is something called post-robotic syndrome. And it's important to talk to families about this because there's not a lot. Once somebody gets post-thrombotic syndrome, physical therapy and use of like compression type devices are really the only thing that you can help symptomatic wise. So what happens is most of these will come in and they'll usually chronically have one leg that's bigger than the other. And this is why, because of the clot that has been there. And then the usual history is I don't have any pain or anything until I get up and I start walking. And, you know, we went to the mall and I was there for 4 hours. The longer you stand, the longer you walk, because you're getting blood flow, but it's not as efficient. Even if you've gotten collaterals, it's not as efficient as what it once was. So you are going to have more edema and you're going to have more pain. The only thing that they can do is sit, elevate, rest, do compression. I don't know if you've seen any of the super stylish compression things that they have. One of the patients that I have has some of the, or had some of the worst clotting I've ever seen. She's really bad post-traumatic syndrome now, and came in and was just telling me that, you know, the pain is worse, and you know, she's been working a lot more. I said, well, where are your compression? She's like, no, the June season is coming. So, how can we prevent this? Sometimes, despite our greatest efforts, there's not necessarily something that you can do. The only thing that we can do is get them started on anticoagulation as soon as you find that clot. Because the quicker you get them on it, then the less time that clot has to grow and get any bigger, and the less likely that they will end up with post-thrombotic. So just a complication to kind of be aware about. Nobody will ask you about that afterwards. But so in summary, remember, always, always, always think about history in these patients. There are lots of components to hemostasis. Nobody expects you to remember all of those ridiculous cascades. If there are ever any questions, don't hesitate to call. You know, any of you guys that stay local, even the ones that don't, remember, you can always call us. Like, I have no problems whatsoever asking questions about, hey, I was in the office, I'm not really sure what's going on. Sound good? Sorry, I went over a little bit and I had to go fast to the interviews, but any questions? Thank you.
Thanks, Dr. Ambrose.
You're welcome.
Yeah.